hip pain, could be lateral hip pain, could be front hip pain, could be posterior hip pain, associated with an activity, and what we'll pick right now is a flexion-based activity. Because that's one of the other ways you can start to classify things. So we do a functional test based off of their functional activity, but also where the pain sets in either happens into flexion, into extension, into cutting, into sidestepping. So you can look at the activity and start to correlate the direction that you're going to assess. So let's say Sandra complains of hip pain with picking something up from the floor. So as she goes to pick something up, like squat lift, pick something up from the floor, she's getting hip pain somewhere. And we do our assessment, we did our functional assessment, we did the biomechanical correction, and then we said, let's do a squat test. We did the squat test, we saw the give, we felt the translation in the hip. So now what we're faced with is a segmental give happening during a squat that also happens during her squat lift in life. Okay, so you see where we are in the stream. Okay, patient comes in, just to backtrack, patient comes in, they're complaining of hip pain. They say, I have hip pain at work because I have to do a lot of lifting. You go through the OPQ-RSTO, you get your information, you feel that this is a muscle strain or joint irritation, something mild. I'm going through my pathomechanical assessment. I say, show me how you lift something up from the floor. I see that she has pain as she drops down into flexion. So I select a squat as my functional screening tool. So I say, okay, go ahead and squat. And as she squats, just go a little bit of a squat, she starts to complain of the same pain that she gets when she lifts at work. I palpate, I feel that the femoral head is anterior. I come in, I do a biomechanical correction, then she squats, go ahead, and it gets a lot better. Okay? So where am I at this point?
Articular breakout.
I want to do a breakout. What kind of breakout?
Articular breakout.
An articular breakout. I went through a functional assessment correlated with her complaint, and I came up with the thought that the driver is the hip, biomechanical correction helped, so then I want to go further into the breakout. Okay? I decided I want to do an articular breakout, and I now know that when she goes into flexion is when we're losing the control of the femoral head. So now I want to further assess that. Okay? So I'm assessing flexion because that correlates to her dysfunction with the functional screening test and the function in life. Good? So we come up to the mat and say, okay, go ahead and lie down for me. I'm going to suddenly change which hip is bothering you. So I say I'm going to do a range of motion assessment. I may have already have done the selective tissue tension test. Let's say in column 1 I did a selective tissue tension test and she was painful posterior hip during passive overpressure. No problem with contraction. Okay? Yeah.
And that's why you rule out under the range of motion non-functional breakout from biomechanical muscle.
Not yet. That's what we're going to do right now. So what I'm saying is we got here because of the functional testing, biomechanical correction. I want to do the breakout. So now here I am in column 3 about to do a breakout, but what I'm layering on is that I may have done some other screening in column 1 because I already knew the hip was involved. So I may have done the selective tissue tension test for hip. And in hip flexion, I discovered right here, I apply overpressure, she says, oh yeah, that's uncomfortable. She may have felt uncomfortable in the front, if that's where her pain is, that's where the pinch is, or maybe she feels uncomfortable in the behind the hip. I did the resistance portion, don't let me push you anymore. She doesn't have pain when we do the resistance. So now my thought is the pain that she complains of is of non-contractile origin, either a hip pinch or maybe something in the posterior capsule, something like that. Okay? I got that from the selective tissue tension test. I know from the subjective and then the functional testing, her pain is flexion based. When she goes into flexion, that's when she gets her pains. Okay. Yep.
So if you bring it into extension and you're testing the flexors and there's
No pain.
then that's why you rule that out.
Well, what do you mean? Ruled out hip flexors?
Rule out the myofascial
We didn't do that yet. We're going to do that right now. Okay? So because you're jumping to structural barrier differential. So that's what I want to do. I haven't done that yet. The only thing that I've done is because of the subjective, I did a selective tissue tension test, I have some data. I did my functional testing, I have very significant data. I have two things that are pointing towards non-contractile articular from both screens. So now I'm about to do an articular assessment. Okay?
During the resistance, you get like, there's no pain, but say they get like, I don't know, impingement of a muscle. Would that count as contractile but that muscle's not actively contracting, so it would still be what, non-contractile?
So essentially that's the glitch with the selective tissue tension test, is that when you do the resistance testing, you still get compression into the hip. So there are times that you can reproduce their non-contractile origin symptoms while they're doing a contraction. Okay, so that's possible. But essentially what you're doing is you're asking them where their pain is. So let's now define, I wasn't trying to go this specific, but let's define anterior impingement pain. Come stand up again. Start to squat down and say ow. And I say, where's your pain? And you point right there. Okay, so I know that her pain is in the front of the hip. Okay? All right, now lie down for me. In the selective tissue tension test, when I came up, I went here, and I said, okay, come up as far as you can. Is that as far as you can go? You okay there? Yes, that didn't bother her. I'm going to now apply overpressure.
Ouch, that's uncomfortable.
Ouch, that's uncomfortable. Where do you feel it? Right there. Okay, so that's two pointing to that. I'm going to test the muscle in the lengthened position. I back off a little bit. Don't let me push you any further. Oh, that feels uncomfortable. Okay, say that.
Yeah.
No, say that.
Oh, ow, that feels uncomfortable.
Okay. Oh, so now I'm like, oh, that surprised me. Where is your discomfort? Oh, okay. So I was testing the glute. So the contractile portion that I was testing was the glute. But when I did that, her hip popped anteriorly and it reproduced her anterior hip pain. So that's the one piece of the selective tissue tension test that you have to work out on the fly. That it is non-contractile pain origin, but it did happen during the resistance, but for a completely different reason. I essentially simulated what happens during the squat. Okay? Okay, yeah.
So now, if she has hip flexion pain, you have to flip her over and go into extension and get the flexors to fire before you can.
So I'm doing my selective tissue tension test. I lower her down. You okay? You okay? You okay? I apply overpressure. Any problem there? No.
No.
Okay, now don't let me push you any further. Hold. Easy, easy. Just match me. Any pain with that? No.
No.
Okay? That's this patient.
So then that would make it more articular in your head.
So it's non-contractile, but I don't know what it is yet. But the biomechanical correction in the functional test makes me lean towards articular.
Okay.
Okay? Now, I could have someone who the pinch was actually happening at their psoas tendon, and now this one would be painful. Okay? But then that matches selective tissue tension test. We have a pain origin contractile structure, the psoas, but it's happening during hip flexion, so there's still an articular component. Okay? So this is triangulation of data. Depending on what you're finding, this helps you to source out what the pathoanatomical issue is. You have an irritated labrum, an irritated anterior hip that's getting pinched. It's non-contractile. All of the active tests are negative, including this one. Okay? But she has pain when she goes into active flexion. Better with biomechanical testing. Let's go after articular to try and figure out what's going on. But my pathoanatomical diagnosis is irritated anterior labrum or irritated anterior joint capsule. I don't know what yet, but to fall into that line. Okay? Pain with resisted flexion. So I bring her into extension, I resist flexion, pain there. I potentially have a psoas tendinopathy that happens to pinch when she goes into flexion. Now that person's pathoanatomical diagnosis is psoas tendinopathy, but it's still a flexion-based pain pattern because it happens when she goes into a squat. So the pathomechanical stays the same. We have segmental translation give during squat that is driven from hip dysfunction. Okay, but two different pathoanatomical diagnoses. Everyone okay there? Any questions on that? Okay, so either patient, this one we're saying non-contractile. I am now in breakouts. I am gonna do an articular breakout. So what do I need to do for the articular breakout? Now,
Range of
Crystal Lee.
motion.
Now what do I wanna look for? What you said before.
Oh, the muscle,
Well, muscle, articular, or neurodural.
oh, this is the range of motion.
This is the range of motion breakout, yeah. Isn't that what you were asking before?
Yeah, but I was also trying to figure out, like, under that bracket, you're looking for those three things, but I wanna know why you would do the myofascial and muscular breakout portion of those three things.
Well, what do you mean by myofascial versus muscular?
Well, isn't it like slash?
It is, oh, okay, so yeah, it's the same thing.
Yeah.
So essentially you're doing a range of motion breakout, the structural differentiation, but you gotta add the other two pieces, muscular, myofascial, articular, dural. So now that's what we wanna figure out. So we're in our range of motion breakout, I wanna know what's going on. I know that there's something going wrong articularly. I know that her pathomechanical issue is anterior translation of the hip. Okay? What are the possible reasons why the hip is gonna anteriorly translate during a squat?
Type.
Tight posterior capsule. Potentially. Tight posterior musculature.
Laxity in the ligament.
A laxity in ligament would lead to what? Yeah, you're right. Well, not full dislocation, but
Translation.
Hypermobility.
potential, some sort of functional instability, potentially subluxation, hopefully not, but essentially a loss of control. Okay? Any segmental translation that happens, it's either, or both, a loss of control or hypomobility somewhere. And in this case, going into flexion, it could be a hypomobile posterior capsule, or it could be hypertonic or tight posterior musculature. Both things would stop the hip from being able to seat in the socket when I went to flex, which would drive the hip anterior. Same idea as in the shoulder. Okay? So I want to know what's going on. So I come in here and I do this. I stabilize, I make sure that I offset, I flex up, right to about there. Is that uncomfortable? Yes. Yes. And let's say we kind of work around the discomfort a little bit. In other words, let her abduct, let her externally rotate a little bit, and I push. And now she says, "Oh, that feels really tight." Go say that.
Oh, that feels really tight.
Oh, where do you feel really tight?
Behind the hip.
Behind the hip. Okay, so I was able to avoid her pinch because I brought her into abduction and external rotation because this will let her pinch. So I'm getting around that, and now she actually feels the tightness. So now I want to know, because right now, is this muscular, dural, or articular? Do you know?
No.
We don't know. No. We know there's something going on here, but we want to figure out what it is. So what can I do?
Could you do the scalar? No.
I could, but that would be mean, because she already has pain
Right,
here.
she already has
Yeah.
Can
So-
you do biomechanical correction?
So we could do a biomechanical correction. So you absolutely could do that. But what could we do that maybe we did right before lunch?
Distraction.
Distraction. All right. So right now we're running into a limitation because of muscle, capsule, or dural. All right. So we're not doing dural yet. But let's say we want to differentiate muscle and capsule. So I come in here and I say, okay, I'm going to place my hand right on the crease of your hip, and I hug in the hip. And now right before the tightness or the pinch, I do a caudal glide, a short axis caudal glide. I pull straight inferior. You okay with that?
Yeah.
I feel that there's some stiffness. Now I hold that, I kind of push into the stiffness, and now I try and flex her, and she says, "Oh wow, that feels a lot better."
Oh wow, that feels a lot better.
Okay. So now remember, I have an end feel as well. So what's my clinical reasoning at this point?
Positional fault. Could be
Positional fault, and due to
articular.
it is articular. But what did we figure out just now? My end feel told me something.
It's posterior stuff.
So it was firm, capsular end feel. Okay. If it was firm, springy, it's like firm, stiff.
Muscular.
It's capsular. If I come in here, and I do this, and now I stop before the pinch, and I go, oh wow, there's a lot of good movement there. And then I say, and she says, wow, that feels great. Okay, now she gained motion, there was no more pinch. I did the inferior glide or the caudal glide, but my end feel was muscular. I had plenty of capsular movement. So what's the reason for the positional fault for that case?
Muscular.
Muscular.
So even though the original end feel without the biomechanical correction was capsular, you're saying when you added the correction, so now you're going through that column, now we're taking away what it's not, and
Yep.
we're going, okay, so then, and that applies.
And I gave, so the one thing that's a little confusing, I did two examples.
Yeah, okay.
I did two examples. One example, at that point, when I pushed down, I had the firm, stiff end feel. That was a capsular end feel, and I was able to gain a little more motion. So I still say positional fault because it wasn't a true impingement. There was a capsular end feel, so I'm saying the capsule was stiff. The second patient, when I brought up to that point, I did the inferior glide, and I felt like there was plenty of motion there. So there was a muscular end feel, no capsular stiffness. I was now able to scoop up and get a lot of motion. Okay? What's up?
For the second one, when you said it's muscular,
Yep.
how are you able to get more motion when you distract?
Because it is a positional fault.
Okay.
So the posterior musculature that was tight as we went to flex was driving that hip anterior and causing the functional impingement. When I came in and did the distraction, I was able to essentially relocate the joint. Not a real subluxation, but essentially I recentered the joint, and now I was really able to roll it forward and get more range, a significant change, but not full, because the posterior musculature is tight. So if I said, okay, cool, on your way, that tight or stiff muscle would still throw off the tracking, feed into the positional fault, still have pain, but now I know I need to treat the muscle. For the other person, there was a stiffness. So I corrected the positional fault, but it's like I'm pushing into a resistant capsule. So when I did that, I got a little more motion. So that makes me feel like, yeah, it's not a real impingement, it's a functional impingement, but I got a lot of work to do because that capsule is really stiff. So now my treatment of choice will be joint mobilizations to try and gain capsular mobility. Okay?
And then, Dr. Rodriguez, what if none of the, like, let's say, if nothing works, at that point, then you go to the next joint? If it's, are you starting to, could you palpate for more, like?
So you would triangulate more data here because something should work. If they do have a true bony impingement way down there, then they're going to have a very positive. There's no very, but their fader will absolutely be positive. You'll feel that firm end feel. You won't really be able to get past it. Most of the time, what's ending up happening is you have room to play. You're gaining motion, but you might run into a bony impingement like way up here. Sorry.
That's okay. It didn't hurt.
Way up here, but you still have the room to work with. That's what's going to happen most of the time, even when you have someone who has a pretty significant FAI. Okay.
So I know when we do our screens and everything has to be compared bilaterally. Like in this situation, because the issue is directly in that hip, would you compare the capsular end feel from that hip to the other hip, or?
Yeah, you still would. Yeah. So if depends on how much time you have.
Okay.
Because you have plenty of data pointing towards this hip, but I do want to know if the stiffness that I feel is normal compared to the other side. And if it is, then the thought is maybe the structure is different on this side, so we can compare for our Craig's test to see maybe there's antiversion, maybe there's something else that's feeding into this, or that the main reason still is control, and we can work on the control. Okay. But highly likely that what you're faced with is the capsule feels pretty much the same on both sides. There's hypertonicity on this side. Treat the muscle, and now start to do your movement re-education, strengthen the hip, retrain the hip, and get them functioning in a different way. Okay? So your treatment can be this. I can come in and I can say I need to gain flexion, so I can just do oscillations. I can do grade 1s and 2s if they're sensitive. I can actually go up as to grade, all the way up to grade 3s to even try and relax, wait, no, that's not legal, right? We're staying with grade 1s and 2s to relax the muscle. You can do 3s too. So stay with grade 1s and 2s to relax the muscle. If it's capsular, you're doing grade 3s and 4s, okay? You can do it to gain motion. So there are techniques that you can do to mobilize while you're moving the hip to try and help to gain motion. If you are thinking that some of what's going on affects more than just flexion, now you can look at rotation. Maybe you can do internal rotation and do other techniques to try and help create joint mobility while you're doing rotation. Okay? So you can utilize different techniques to get a sense of what sort of motions can I do to help to relax the muscle so I can gain motion, or is there capsular stiffness when I go into internal rotation and I really need to mobilize the capsule biased for internal rotation, and that's going to help the flexion. Okay? Does that make sense? So, what kind of techniques would those be, you might ask?
So we love Mulligan. I love Mulligan. But he has a lot of these mobilizations for this positional fault issue. So especially, he uses the lateral glide is kind of the key mobilization with movement. So that's what I'll go through first, is lateral glide to improve flexion, lateral glide to improve internal rotation at the hip. And the concepts are going to be very similar as all the other concepts throughout. It's a sustained mobilization with repeated movements. So we're going to do repeated movements into flexion, and then we'll do repeated movements into internal rotation. So this is something that you'll find in Mulligan's book. There's some evidence behind it. It's a technique that he uses quite frequently. Then we'll discuss some other ways that we can use the belt to accomplish similar tasks that Dr. Rodriguez just showed you, such as an inferior glide. We can do that with movement, which is essentially what he just did. But a lot of these, because they're in the hip, especially for the lateral glides, we like the belt because we're dealing with some really sensitive areas. So I would say if you took that short axis distraction that you were doing and you kind of turned it 90 degrees medially, a lot of people would be quite uncomfortable kind of putting their hands in there. So the belt is a nice alternative to that, to get that lateral glide. So setup's going to be pretty similar, depending on the belt you have. Usually, because we're pulling on some of the adductor soft tissue, and adductors can be a little bit uncomfortable, you'll put a towel in there. I won't do a strong glide for you, but I'll just kind of set you up for it. So usually just kind of a little bit of a buffer in here. So you wrap around. So you're going to get as far proximal on the femur as you can comfortably for the patient. So obviously, just as with any glide, you want to be as close to the joint that you're mobilizing without crossing over that joint. So the belt allows me to come in here. Table height is going to be variable for you. Are you okay here? Is that okay? So we're going to start with the flexion mobilization with movement, which means we're doing a lateral glide with flexion. So I'm going to be right in line with her leg. We're going to get into that same kind of butt out glide that we're doing. And in here, I'm really going to get into a position where I have her just kind of hugged here because I'm using my body to do the mobilization. You feeling okay?
Yeah.
So as I kind of kick my butt back, we're getting the glide. So this is a lateral glide. So kind of like the short axis distraction, my sternum is providing that pivot point so her whole leg doesn't fall out toward me.
So under your ischial
tuberosity, correct. So right under the ish tube there. For females, if you want to put a pillow, just kind of for protection, that's okay as well. Or you can just kind of put your hands in front if you're more comfortable that way. And it's all a side bend movement. So you apply the glide. You're going to be saying this should be, because it's a Mulligan movement, should be pain-free. So you're saying without the glide, ouch. So then you're going to reapply the glide. And as you side bend and flex their hip, they should say, oh, that feels a lot better. I no longer feel that pinch in my hip. I no longer feel that pain. And again, this is correcting a positional fault of that femoral head. So we're going to do about a 2-second hold, come back, and we're going to do 10. And then we're going to reassess that movement and see if the glide translated to reducing that comparable sign or that comparable sign. Question?
How do you know to do this as opposed to the inferior?
So you're gonna test out both.
Okay.
So if the inferior, say for example, the inferior didn't help as much as you would like, or if it helped a little, and you tried this, then lateral glide. So you try it. So it should completely eliminate the pain. So the other one, we know that one of the impingement positions, that's why we do that, adduction, internal rotation position is very uncomfortable. So if we had internal rotation that we felt was our more comparable sign than flexion, the lateral glide also really helps with internal rotation with that positional fall. So we would do the same thing, except before we would test our internal rotation, we'd see where it is. You okay? Is that uncomfortable for you?
Yeah, I'm good.
Okay. So same position, we're here, except instead of side bending this time, we're gonna come here, same thing, we kinda hug the leg, and we're doing our glide, so butt out till you get that pull, lateral glide, and you're just rotating your body. Now we don't internally rotate nearly as much as we flex, so we're just doing a nice little trunk rotation, you're okay. Again, this should be pain-free, that should be the kind of the response that you're looking for. So it would have been, ouch, that hurts, apply the glide, do the rotation, oh hey, that doesn't hurt anymore, and you get more motion. Question?
So we're buzzing around, like I guess like the range where they're having the issue,
Yes.
right? We're not going all the way through flexion.
So we're not going, no, so we're starting just before, so for flexion, absolutely. So if it's 90 degrees of flexion where she's having her problem, we'll start with the foot on the ground and then go through that point. But no, you don't have to come all the way out into extension and up. Same thing with internal. You're really going from neutral to internal. You're not going all the way to external and back into internal. Okay? So those are your Mulligan mobilizations with movement. Now, if we found that the inferior glide was pretty effective and it's something that we've chosen to use as a mobilization technique, we can use the belt for the same purpose, and we would just change our position. So we're unlikely to get a kind of a true inferior glide. It's got a really long belt or stood all the way back there, but it's really going to be a slightly inferolateral glide. However, with the position of the acetabulum, that would make sense. So an inferior glide really should be directed a little bit laterally based on the position of the femur. So we can come into the same position. Everybody likes to take credit for different things, so just as Brian Mulligan with those two mobilization with movements, when I was taught this, it was by an IPA certified therapist, so they took credit for this one, I guess. IPA is Institute for Physical Art, just different people that wrote a book and make a lot of money off their courses. But it's the same thing, right? It's an inferior glide. Different people do this, they just call it different things. So for this one, I can do something very similar, and I can kind of pull my butt out, and I can flex her as I go. And I don't have to move my body here mechanically. This is a little bit tough because I'm far away from her hip as I apply the glide. So to keep the glide and rock my body forward are kind of counterintuitive. So I can use my arms here a little bit if I have to. So just keeping that glide all the way through. So inferior glide, you feel okay?
Yeah.
As I flex to help clear over whatever's pinching in the front of the hip. Cool. Good. Good.
Let's practice.
So, try it out.